optimizing couples' preconception health to enhance ART outcomes. I invite you to explore with me a question that continues to puzzle us all. Why do seemingly good prognosis couple face repeatedly IVF failure? And even we have our advanced reproductive arsenals, we still face that setback of IVF. So if we go back to the history of assisted reproduction, in 1940 there was intrauterine insemination introduction that enhances the successful pregnancy rate. In 1978, the first IVF baby, Louis Brown, a landmark, it was a dramatic landmark. It revolutionized the all infertility outcomes. Then in our 1980s and 1990s, our assisted hatching, intracytoplasmic sperm injections, and pre-implantation genetic diagnosis remarkably brought solutions for male infertility, genetic diseases, and implantation failure. In 2000s, vitrification and advanced enhanced imaging techniques, they improved embryo survival and embryo selection. And now with artificial intelligence and in vitro gametogenesis, it still holds further promise for our reproduction success. But when we look at this graph, there's a paradox. The blue line, it indicates the tremendous advancement in the technologies. But this orange line, it shows it is disappointingly flat. Our success rate has not improved remarkably. It's still like around 40%. And now look at this intriguing gray line. It represents preconception metabolic health, and it has the potential to bring this success line up by 10 to 20%. So what this gray line represent? What is this preconception metabolic health? Our three metabolic pillars: vitamin D, ferritin levels, and 1 hour postprandial glucose. And for an optimized healthy embryo, we need to have fertility range for all these metabolic pillars 6 months before assisted reproduction in both partners. So what is optimum fertility range? For vitamin D, it should be between 40 to 60 nanogram per ml. For 1 hour postprandial glucose, it should be less than 6.7 millimole per hour per liter, and optimized level of ferritin should be between 50 to 80 nanogram per ml. Now, why did I say for 6 months? So first 3 months, we all know that one cycle of folliculogenesis and spermatogenesis, it takes around 3 months. So first 3 months to wash away those gametes that has developed in an abnormal conditions, and another 3 months to nurture those gametes in an optimized environment. So what happens when these levels fall beyond our optimum levels? All the three, it brings molecular damage, though through a different pathways. And these three metabolic molecular damages are oxidative stress, epigenetic dysregulation, and mitochondrial dysfunction. And they don't work in isolation. They are intricately intertwined with each other, and it becomes a vicious cycle. So once we understood that what these abnormal level causes, how it causes molecular damage, let us see individually on what pathways they bring molecular damage. So if vitamin D is deficient, if it is less than 20 nanogram per ml, okay, before that we have to understand that vitamin D is not just a vitamin, it's a pro-hormone. And vitamin D receptor and its activating enzyme 1-alpha hydroxylase, they are present in ovary, eggs, sperm and endometrium, and that shows that they are involved with our oocytes and endometrial receptivity. So when there is a deficiency, it causes impaired vitamin D receptor activation. That causes inadequate expression of these antioxidant enzymes like our glutathione peroxidase and superoxide dismutase, and that disturbs the redox balance. Antioxidants are less, defense is less, our reactive oxygen species they are more, that causes oxidative stress. Then along with that, there's also impaired vitamin D receptor signaling. That affects the regulation of epigenetic enzymes like and that causes aberrant DNA methylation and histone modification, affecting the genetic imprinting of endometrium. So, and this is for deficiency. If there is an excess, it causes hypercalcemia, hyperphosphatemia. And when mitochondria is overloaded with calcium, it directly damages the DNA, causing oxidative stress and mitochondrial dysfunction. Our next pillar, glucose spike. So even when there is a mild spike of the glucose level after meals, it causes a cascade of damages. We can do analogy with the domino effect. So our first domino is high level of postprandial glucose. That causes non-enzymatic glycation of nucleic acid, lipids and proteins, and they produces advanced glycation end product. Now the second domino, that binds to its receptor called receptor for advanced glycation end product, and that leads to profound pro-inflammatory pathway, nuclear factor kappa B and NADH activation. That brings to unleashing of oxidative stress, oxidative damage, mitochondrial dysfunction, epigenetic dysregulation, and the last insult will come on the cellular consequences, what we always see. Our fertilization failure, implantation, poor implantation, miscarriages rate, and ultimately reduced live birth rate. Our third metabolic pillar is ferritin, the Goldilocks micronutrient. So the level should be just right. If there is a deficiency, it can cause by multiple pathways this molecular damage. Iron is an important component for ferrous sulfur cluster, which is very useful cofactor for the our electron transport chain. So when there's a deficiency, there's no clusters and it causes electron transport failure, reducing ATP production, and gametes are starving of energies. It also causes aberrant DNA methylation and histone modification by not getting this DNA demethylase and histone demethylase enzymes, they remain unexpressed. And the third is iron is an important component activating enzyme for ribonucleotide ribonuclease reductase to change RNA into DNA precursors. So when there is a deficiency, ribonucleotide reductase remains inactivated and it causes failed cell division and repair. So all these three causes molecular damage. And it also subtly causes Fenton reaction, which is Fenton reaction is most prominently seen by excess of ferritin. So when there is excess of ferritin, there is a labile of these iron molecules that causes a toxic reaction. the H2O2, hydrogen peroxide, which is usually non-toxic, it changes into reactive oxygen hydroxyl radical, and this hydroxyl radical causes lipid peroxidation, damages the mitochondrial membrane, mitochondrial damage, and ultimately it induces iron dependent cellular death, ferroptosis. And the same thing is caused by when there is a very low ferritin also, because it is stored very loosely in the ferritin molecule, and it can cause subtle Fenton reaction. So that is interesting. Both excess and deficiency can lead to these things. So we understood the molecular damage caused by different pathways by different metabolic pillars, and these damages, how does it causes? In eggs, it causes meiotic spindle asynchrony, resulting in oocyte error and euploidy. Oocyte activation fails. It causes poor implantation in the endometrium, and these oxidative enzymes, it is very destructive for the sperm DNA, causing high DNA fragmentation risk. It also affects the viability and motility of those sperm. It affects Sertoli cells, Leydig cells, causing defective spermatogenesis and steroidogenesis. And all these things bring one clinical consequences: reduced fertilization rate, poor embryo quality, implantation failure, higher miscarriage rate, and ultimately lower birth rate, live birth rate, sorry. So when we say that you have a mechanism but no evidence, it's just a story. And evidence without mechanism, it's just a coincidence. But we have both. Mechanism we have just discussed. Let's see what the evidence says. So there are multiple meta-analysis done in IVF patients, and it has been observed repeatedly that women who were vitamin D replete, they have much higher, 30% higher live birth rate as compared to those who were deficient in vitamin D. And interestingly, when the supplementation studies also have proved that those who have received supplementation as compared to placebo, they have increased their live birth rate. And these effects are more pronounced in those women having metabolic disorders like polycystic ovarian disease and insulin resistance. That again shows there's a close association. For isolated postprandial hypoglycemia, level 2 large prospective cohort has shown that even isolated 1 hour postprandial glycemia, it can reduce the live birth rate, it increases implantation failure, despite having normal fasting blood glucose and normal HbA1c. Those are the tests we usually do for our couples. Then the glycemic variability detected by this continuous glucose monitor. Even the minor variations, it reduces the blastocyst formation and embryo quality, it gets impaired. Sorry, for our third pillar, ferritin, it has been continuously been shown that ferritin deficiency reduces oocyte yield, reduces fertilization rate, reduces embryo quality, and also when even single IV iron infusion of iron carboxymaltose has improved the live birth rate. Similarly, for ferritin excess, we have systemic reviews which has shown increased risk of hypogonadotropic hypogonadism in both male and female, and that causes sperm production. And we know our cases of hemochromatosis, they have this risk of hypogonadism causing infertility. So what we have mechanism, we have evidences. So now we have to be proactive. Presently, guidelines shows these tests, screening tests only when there are high risk cases. Like for vitamin D, we do vitamin D, it is recommended to do vitamin D only when there is a polycystic ovarian disease or recurrent implantation failure, darker skin, limited sun exposure. Serum ferritin is advised only if there is a suspicion of iron disorders or suspicion of anemia. And 1 hour oral glucose tolerance test is usually not done. It's only we are doing when there's a high risk of family history of diabetes or recurrent implantation failure or recurrent IVF failure, a history of macrosomic babies. So only in selected cases it is recommended by our guidelines. We propose screening, universal screening for both the partners 6 months before assisted reproduction techniques. And it's doable, it's actionable. So when it is vitamin D deficiency, everyone knows that 50,000 international unit weekly or 60,000, I think they are different, in different countries there are different strength available. So for first 6 to 8 weeks, we can give the high bolus dose and then maintenance dose for another 6 to 8 weeks. If there's an insufficiency, then we can start with the low maintenance dose for 12 weeks. We must check before we do the our IVF or whatever things. We must check and make sure that it is reached to the sufficiency level. And it could be, you can tailor this therapy. Sometimes when time is limited, we can continuously give our high doses up to 12 weeks. When there is excess, it is usually due to unmonitored self-administration of vitamin D. There's a big media narrative that we all need vitamin D for multiple benefits. So the treatment is you have to stop all supplementation, you maintain hydration. If there is hypercalcemia, then you treat it. If you suspect some other metabolic disorders, you have to go on that line. Postprandial optimization, very easy. This happens usually, it's like first indication of risk for the diabetes, and it is due to first phase insulin failure and due to increased resistance for the peripheral tissue against glucose level. So it is easy to treat. We have to use insulin sensitizer, and we know that lifestyle modification, weight reduction, myoinositol, it has proven effect. It is like an insulin sensitizer. And if you need, you can add metformin. Depending on case to case, you have to use your own tailored therapy for that. And monitoring, ideally it should be done by a continuous glucose monitor. But if it is not available, you can do self-monitoring at home by blood glucose. It is an acceptable approach. So our target, you know that it has to be within range before we do any reproduction technique advanced level. Even for normal conception, I would say that if people are coming for prenatal checkup, prenatal counseling, we must do these tests. Every pregnancy is precious pregnancy. For ferritin optimization pathway, if there's low ferritin, iron supplementation, our goal is to achieve level above 50 to 90 nanogram per ml for 3 to 6 months. When it is high ferritin, so for women, if it is 200 nanogram per ml, and for men, if it is more than 300 nanogram per ml, we need to do CRP level to rule out the inflammatory causes for the ferritin excess. We must do transferrin saturation level to diagnose whether it is true iron overload or any metabolic disorders, underlying disorders, and accordingly we have to do. So the treatment is for ferritin excess, iron chelation or phlebotomy. Here, though it is out of context, but I would like to say that usually it is called therapeutic phlebotomy, where they take the blood and throw it. But now the evidences are there that these blood can be used to those who require it, those deficient anemic patient or anyone. And it has been proved that these, even if they have hemochromatosis, even if they have HFA genotype mutation, it doesn't pass through blood transfusion. So instead of throwing it away, we must use it. And it is highly concentrated, so it's more useful. Now we have seen our optimization, which is very clear, actionable, doable, and accessible. Even in poorer countries, these are the simple methods to optimize the level. If you see the cost comparison, you can see the big bar of this orange. It is for the standard IVF price, $10,000 to $12,000, just standard one. As compared to comprehensive cost for screening and treatment, it's not more than $300, between $150 to $300, just 2% of the IVF cost. And not only it is cost, it's also your emotional, physical burden, your burden of having IVF failure. Many couples, they just leave it and live in a depression, psychological trauma. And not only we are gaining the fertility or pregnancy, there are other advantages of it. By not diagnosing these treatable, reversible root causes, and we are labeling those couples having unexplained idiopathic infertility. And the second thing, we are missing a window to prevent chronic diseases like hemochromatosis, hypercalcemia, your diabetes. We can diagnose it very early by doing these simple screening tests. So now I have given you all compelling facts and ideas and evidence and mechanism, but it's very reasonable that we should address the controversies also, being a scientific people. So what is the most critics? Most critics, they raise the question that there's no mega randomized control studies with live birth rate as an endpoint. Yes, it is true, and RCTs are the gold standard evidences, but we have consistently level 2 studies that has shown an association between these three pillars with infertility results, along with strong mechanistic biology. So we can't ignore these simple, doable, simple screening tests. It's time to act. The second, few people, they question that these are confounders, like there are confounders in these studies like BMI, lifestyle, genetics, and these complicate the result. I would say it's not a weakness, rather it is a strong point that in spite of all these confounders, we are seeing repeatedly positive associations. And the third is that these are markers, not the cause. But these are not markers. We have seen that when we maintain the level, when we optimize it, biology changes, mechanism, it works on the mechanism. It drives the process. And the fourth, that our guidelines, ASHLE, ASRM, they are still silent and they suggest only in high risk cases. But history suggests that these guidelines they take our clinical observation that leads the guidelines. And there's always a gap between the clinical observation and the recommendations. Just for that, we can't ignore this simple screening test. So what are my key takeaways? The metabolic triad is a simple, high impact, low cost liver. Screen both partners. Metabolic dysfunction is often clinically silent. And third, optimize the metabolic diet first. It's a mandatory pre-ART step. When there was I saw the opportunity for this conference, it didn't take me more than 10 minutes to decide what topic I'm going to discuss. Because this I'm seeing every day in my clinic. In Botswana, there's no IVF facilities. So patients, they go to their home country or South Africa, anywhere, and they come to us with 2 IVF failures, 3 IVF failures, and one couple who recently came, both were less than 35 age. Their wife was 29, husband was 33. 2 repeated IVF failure in a very good IVF center. When I examined them, wife was having 4.5 nanogram per ml of vitamin D, and husband was having frank diabetes. They just do semen analysis. If that is normal, they don't go further. No history taking from male partners are usually ignored. So it didn't take me 10. This was going on in my mind from many, I would say, like I was on top. I wanted to spread this message to the world. So I want to end with this. The embryo's fate is written as much in the metabolic code as in the genome. Let's decode, correct, and give life its best chance. And to complete my story for that couple, after 6 months, they conceived spontaneously.
Well done.
Thank you. Thank you.
Saka, question and say.
Questions, comments, suggestions, please.
Can we put up the third but last slide? This is
Yes.
extremely clever to put up this, because I was already
With those
inhaling
questions.
so compliment on this strategic thing.
Thank
But
you so much.
the strongest thing I think to be said about this whole thing is it will not harm. Right?
That's true.
And it will have, even if it doesn't lead to the desired endpoint in the individual couple, it will still have a benefit on their health, on their general health.
Yes.
Yes.
And the second one is, maybe this is an additional comment. You know, all the obstetricians know it in the room. Pregnancies in obese women can be achieved by forced IVF, but they give bad trouble once they're ongoing. And even worse so if it's twins. Right? So the IVF center I work with, if I have an obese young woman, I say, they will send you away. So go to the metabolic consultation, try and lose weight as much as you can, and once you've done that, then you can also, you have a higher expectation of getting a healthy baby and having gendering a child that will not have the same troubles as you have with your overweight.
Thank you for that addition.
I highly recommend you on both the content and the positioning of the slide.
Thank you so much. It means a lot to me. Thank you.
I too would concur with Dr. Martin Salim that this is one of the best presentations, coming from a doctor of repute. Presentation skills wonderful, and the position of the style of course. Yeah. Anybody else? Any comments? Queries?
Yeah, I thought it was absolutely fascinating, especially I've got a background in biochemistry as well. So for me, what was fascinating and what I'd never really thought about before is the same thing that they're looking at now for anti-aging, the same sort of, the vitamin D and the optimization of that, the antioxidant things, how the reactions occur, the reactive oxidative species, the DNA methylation, the same things occur in gametes as well, and the same process, which I'd never really made the connection. And it's such an easy, cost-effective thing to do. And as you said, not just for conceiving, but for your long-term
Overall health.
health and wellness. You mentioned wellness, which is such a, in all social media, you can't trip over and you know, come across the word wellness, and to optimize your life as well. And these are such easy things to do. And as you say, I think, you know, giving any counseling to any couple wanting to conceive, rather, you don't have to limit it to just IVF pregnancies. I think it's really good. Thank you.
Absolutely.
Yeah, just one comment I will make. Despite all the propaganda, all the media, all the, counseling, human beings, they don't listen. They don't listen. The number of KFCs, the number of McDonald's, number of Pepsi, the soft drinks, and alcohol, tobacco. Despite, I am lost for words actually. Why don't we take it in?
Yes.
Even as doctors, we don't listen. You see so many obese doctors smoking, alcohol. I mean, it's just a thing that the message doesn't seem to get across, even to doctors. So what about lay people? And so where does the government come in? Where does our community come in? Where is the responsibility? Whose responsibility is it? I mean,
We are living in an obesogenic environment.
Yeah.
What did you eat at the time of coffee break?
Yes.
What did we eat? We ate all junk.
That's it. Yes.
So being a doctors, we
Yeah.
know everything, but we are living in that environment, and
And
it's another interesting topic for me, and I always talk about it, about the obesity. Anorexigenic pathway, orexigenic pathway, and then the hedonic pathway. That hedonic pathway.
That's the worst to fight.
yes.
Do we explore any other ways to celebrate our birthdays, our celebrations, our award, our all these occasions, our festivals? We are all full with junk food.
That brings us to the close of the pre-coffee session, and with this kind words of wisdom, and I think for practical adoption, I think we can go in for a very short coffee